Medurstand. Understanding medicine.
I am Professor Aziz-ur-Rehman, and today we are going to talk about pacemaker. Since we are discussing various ECG manifestation of various blocks, so I think basic purpose of this video is to enable you to recognize pacemaker rhythm on ECG, but we will have very brief discussion about what pacemakers are and what are their indications. This is our curriculum. We have covered up to fascicle block. Today we are going to take up this pacemaker rhythm. My affiliations shown here. Now this picture I have shown you earlier also, but just for the sake of orientation, our pacemaker, the normal pacemaker is in the SA node. But if that does not work, then AV node will take over, and then if that doesn't work, then any of the distal branches or any part of the conduction system has got an built-in pacemaker, but they are kept suppressed because the law of nature is the pacemaker with the fastest inherent rate will govern the heart. So normally SA node has the fastest, otherwise as you go distally, the inherent heart rate, the pacemaker rate is low and low. So pacemaker may be needed if there is an ectopic pacemaker in the heart, but that is too slow or too unreliable. And there are several indications. I will cover them very briefly. So this is the picture, and you can see this is the permanent pacemaker planted somewhere under the skin, mostly here in the upper part of the chest. Then these are the wires. This is basically an electronic device with very long battery life, and this will generate a small current which will go through these wires, and they will stimulate atria, ventricle, and also the modern pacemaker, they will sense if atria, ventricles have their own contraction, so it will be giving current only when needed, so-called demand pacemaker. And then these pacemakers also have the ability to inhibit the tachyarrhythmias. So I think very briefly I'm going to show you what all this means. There are various types of pacemakers. One simple difference is temporary versus permanent. For example, somebody develops acute AV nodal block because of inferior wall infarction or because of certain drugs or some other toxicity. So we are assured that this condition is temporary. A permanent pacemaker is not needed. A pacemaker is the lead is passed into the heart and the device is kept externally, and we hope that after some time patient will recover and will take out the lead. But if the condition is permanent or is likely to become permanent, then permanent lead is placed through these veins and device is implanted under the skin. Then full-time versus demand. Demand pacemaker is the one if somebody, for example, full-time would be needed if somebody, imagine somebody's heart does not generate any impulse at all. That person would need full-time pacemaker because there is no intrinsic pacemaker at all. But if somebody has a pacemaker which sometimes works, sometimes doesn't work, SA node works or sometimes doesn't work, or sometimes then a patient may be given this demand pacemaker. That means the lead, this will sense if there is intrinsic rhythm, pacemaker will be kept shut off. But if there is no intrinsic activity, pacemaker will wait for a few milliseconds, which will be programmed, of course, and after that it will take over and it will continue to work as long as there is no intrinsic activity. The moment there is the heart takes over, then pacemaker will be one of the will sense, and that the pacemaker will shut off again. And this is number one, to prolong battery life, and number two, avoid fight between pacemaker and one's own rhythm. Then various types, best is triple D, and D is dual. Dual means both atria and ventricle. Now what exactly is meant by triple D? First D is the one which senses from atria and ventricle. So it would see if there is intrinsic electrical activity from both atria or ventricle. That is the first D. And second D which stimulates both atria and ventricle, right? Because there is no conduction, for example, AV node is completely blocked, then current is provided to atria, and after a delay, just equivalent to delay in AV node, a separate current is provided to the ventricle. So there will be a dual chamber stimulation. Then inhibits atria and ventricles. If there is a tachyarrhythmia, it would inhibit whichever chamber this arrhythmia starts. So I think you can imagine the best pacemaker for permanent condition would be a triple D demand pacemaker. Then there are some devices which are just like pacemaker. They actually have pacemaker functionality plus additional functionality. Implantable cardiovascular defibrillator. Somebody has VTs, ventricular tachycardias, ventricular fibrillation. This device will pick up and that internally defibrillate. Similarly, there are cardiac resynchronization therapy. This is beyond the scope, but just briefly, this is a kind of system which will make sure that the whole ventricular system is depolarized simultaneously to make an effective contraction. This is actually synchronization devices. What are the indications of pacemaker? First of all, complete heart block, which is permanent. Of course, a temporary complete heart block can occur in, for example, medication, toxicity, or inferior infarction. So then it would be temporary, but otherwise there would be permanent pacemaker if there is complete heart block. Then high degree AV block. High degree AV block means, if you remember the second degree block, the three types. High degree AV block means that one P wave is conducted to ventricles, but alternate P wave is not. Or maybe two are conducted, third is not. That means many P waves are blocked. So there is a high risk of this kind of block progressing to complete AV block. Mobis type 2, because this is actually the rhythm is governed by a pacemaker which is distal to AV node, and this is also not very reliable. This can also progress to third degree AV block. Then sixth sinus syndrome. I think if I say that if the cardiologist feels that this arrhythmia second degree block is likely to progress to third degree, that is the indication for pacemaker. Third degree, of course, is the indication. Sixth sinus syndrome is a condition where patient has some problem with the SA node and it is so unreliable. Sometimes there is severe bradycardia, sometimes there is severe tachycardia, and sometimes we have to put the permanent pacemaker here also. This may be incomplete list, but as I said, this is actually not a module on pacemaker. The cardiologists, they know it better. So this is just a brief introduction. Now let me have your input. You please see this ECG. As you all know, whenever we look for rhythm problem, and pacemaker, of course, it will come under that category, we see the continuous lead. There are problems here also, but we will see the continuously recorded ECG lead, which is limb lead 2 here. So if you scan from this side toward right, do you see any P waves? This one, for example, this first one, this one, do you think it is a P wave? No, it is not. Although the location on ECG is exactly the same as you would have on P wave, but this is very narrow, and very tall. So it's not the morphology of a P wave. Then you see another similar, very sharp and very narrow, even taller. This is electrical activity. This one is also electrical activity. Can you make a guess? What could this be? And this is repeating in every, this is most probably a QRS complex, broad one. And before every QRS complex, you see these two spikes with the same distance. You see this? Even here also. In all the leads, every broad QRS, which is not exactly of normal morphology, is preceded by two very sharp and very tall electrical activities. This is actually dual chamber pacemaker. This patient has got no rhythm of its own. This is permanent pacemaker, and the first is the electrical activity delivered to atrium. Actually, this is not atrial depolarization. This is the electrical activity given by the pacemaker. So that is why of this morphology. P wave should be there after this spike. And the second, this sharp is actually another electrical activity given to the ventricles. This is the electrode in the atrium. This one is electrode in the ventricle. So it's a dual chamber pacemaker in a sequential pattern because of the programmed system in the pacemaker. First current is given to the atria to allow atria to depolarize and contract. After a delay, just equivalent to the AV node delay, another current is given to the ventricles to allow ventricles to depolarize and to contract. So this is actually an attempt to reproduce the exact normal physiological state. If I enlarge this one, I think you would see it better. So this one, the first one is paced P, this one paced R, but then actually P wave should be as a result of this pace current. This one is perhaps atrial depolarization and this is QRS. Now this QRS is in response to this current. Okay, so if you see an ECG which has got two sharp spikes preceding a QRS complex, it should be called a dual chamber pacemaker. If somebody has just one spike, there is no this spike, this one is not there, then it may be the problem is then not in the AV node, then problem is perhaps in the SO node, and that person has got single chamber, the atrial electrode, not the ventricle. So there will be only one spike followed by QRS complex. Or there may be just one spike in the ventricle. Sorry, this is actually more likely, not in the atrium. There is just one electrode that is in the ventricle and that stimulates ventricular depolarization. So we just forget the atria. The atrial contribution to cardiac output will then be will not be there. So these are actually old-fashioned. I understand all modern pacemakers are dual chamber. What about this one? Now you see two things here. One is very similar to the one we saw. You can see this is the QRS complex preceded by a spike. This is very big spike, very big. Perhaps this is an old-fashioned bipolar pacemaker. Bipolar is the one with one pole in the heart. The other pole is the I think the battery itself. But these new have just very small, just like the audio pin, two electrodes very close to each other. So the new pacemaker, they might not actually show a spike on the ECG, but if you see these big spikes, this is likely to be an old-fashioned pacemaker. Now you can see these are all paced beats because these QRS complexes are preceded by two spikes, but this one is the natural automatic normal heartbeat. So here pacemaker did not work because it was not needed. Thank you very much. So this was, as promised, a very brief introduction to pacemaker, their indications, and how to recognize pacemaker ECG, ECG with pacemaker. I hope this was useful to you, and I really look forward to see you in my next video. This is Professor Aziz-ur-Rehman from Medurstand.